We're at the IAS meeting in Paris. We're here with Karine Lacombe, and she is with the hospital right here in Paris,
Saint-Antoine Hospital,
which is important because, you know, we're appreciating that you're hosting this conference. And
Thank
so
you.
many good hospitals here.
Oh, definitely. Definitely a wide range of hospitals.
And research, a lot
Definitely.
right here. So we're going to talk about two things here. One is what you presented regarding the combination of HIV and hepatitis. You did a research project in South Africa. And then you have another research protocol that you just presented just recently. So let's start off with the work that you did regarding the combination, combining the HIV and hepatitis in the context of treatment.
Okay, so this is a trial. Well, in fact, that's a research project that we have developed in sub-Saharan Africa, where we wanted to address the problem of the liver-associated mortality and morbidity due to viral hepatitis, and especially hepatitis C. And you know that the access to treatment for Hep C in Africa is very, very difficult because there is no human resources. The diagnostics, screening procedures are very scarce and very expensive. And on top of that, the access to direct antiviral agents for hepatitis C is very, very difficult. So we have designed a program that aims at showing the efficacy and tolerability of a combination of DAAs for hepatitis C. And this program has been implemented in HIV-infected patients as well as non-HIV-infected patients, to show that there is no difference in those groups and that patients infected with HIV respond as well as those without HIV to hepatitis C treatment. So we showed that the efficacy was above 90%. So 90% of the patients were cured of hepatitis C, and there had been no impact on HIV on the efficacy of treatment, which is a very good news for countries where HIV prevalence is very high. It means that we can treat those patients for Hep C as we do for Hep C monoinfection. So this is a very good way to advocate for larger access to DAAs in resource-limited countries, and especially in Africa, where access to treatment is tremendously difficult. So in terms of DAA associations, we use sofosbuvir and ledapatvir for genotype 1 and 4, and we use sofosbuvir plus ribavirin for genotype 2. And the efficacy was about the same. The tolerability was excellent. Adherence as well was excellent. And we could prescribe that with a wide range of ARVs in the HIV-infected patients. And just to set up the scene, there was an international trial in Cameroon, Senegal, and Côte d'Ivoire, 120 patients. So that's very encouraging.
120 patients total?
Yes, in total. So it's a very encouraging trial showing that access to treatment in Africa is feasible and that we really have to advocate for that.
Do you feel that you need to do further research to confirm the results, or you feel comfortable with where you're at?
Well, I think that now we have to invest, not really in showing the efficacy of treatment, but more before treatment, which means screening, because there is a huge gap in screening. There is no universal screening for viral hepatitis in Africa. That's a big problem.
So you don't even know what you've got in.
Exactly, because if you want to treat patients, you have to identify those patients. But if you can't screen, then you can't identify them. So very important to invest in research for screening strategies, and especially simplified screening strategies, because the tools we're using in rich countries cannot be applied in resource-limited countries. In rich countries, we have central labs, we do molecular analysis, and it's just impossible in resource-limited settings. So we have to develop point-of-care tests, and those tests have to be evaluated in a cost-effectiveness analysis to find out which strategy is the best cost-effective in a resource-constrained setting.
Do you feel it might be good to find a way to do on-site testing and evaluation? So in other words, would it be a
Definitely.
kit, maybe a kit that you would
Definitely, that would integrated what we call integrated service procedures, integrated screening procedures for HIV, hepatitis C, and hepatitis B, and then trigger the test and treat strategy for HIV and hepatitis C.
test and link to care and then get into treatment and so forth?
Exactly.
So it seems like you've got a good way to approach it, but there's still a lot of the infrastructure that has to be developed, I think.
Yes, so I think that we have to rely on what has been developed for HIV. You know, there are many HIV healthcare centers around in remote areas, even primary healthcare centers that deal with HIV. So we could really just implement the hepatitis care and management in those clinics and work on a synergistic way with the HIV specialists. And most of the time they're the same, you know, hepatitis specialists, HIV specialists, or not even specialists, just, you know, general primary healthcare delivering services. Very important to invest in decentralized care.
So do you feel like the work that you're doing is going to be political, or is it going to be just budgetary, or
No, I think that we are bringing the scientific proof to push forward the political will. So I'd like, we are right now updating the WHO guidelines for hepatitis C. So we're going to provide data from sub-Saharan Africa, showing that it works there, and that, and by that, it will, the WHO will disseminate the results, integrate the results in the guideline, disseminate the results, and then locally, you know, the governments will be able to take those results and then to implement strategies to fight viral hepatitis, because the local governments always need to get, you know, some guidance, especially from WHO for communicable disease. So I think that's it should bring, you know, more scientific ground to political decisions.
Apart from the human drama that's playing out, do you feel like this is something that would be then cost effective? In other words, less sick people, you know, and of course going through that process, and less more work hours for people that would be otherwise, you know, working. They would be sick.
Yeah. Oh yeah, definitely. That's very important, especially when you have a disease which can be cured, like 99% of the cases. And we know that on the long term, hepatitis C can be very deleterious, and even in patients without real liver disease, we know that it increases the fatigue and a wide range of symptoms. And in Africa, where there are so many concomitant diseases, curing hepatitis C is very, very important.
How do you follow the, you know, in our country, in the United States, there is this concern about reinfection, which can happen. Of course, that's a drama that you don't like to see play out, but it is very possible. And I don't know how we're going to resolve that issue, but other than just with education. What people used to go through in the old days, I think our focus this year is past, present, and future. Well, the past, we had terrible treatments, and they weren't very efficacious. But now we have the real possibility to treat and cure. And the future is, of course, then with a population that's now living well, and less people that are reinfecting others. The reinfectability is, of course, another consideration.
Yeah. So you're right, reinfection is a real issue in patients treated and cured for hepatitis C, but it's a problem in two specific communities: the community of people using drugs and the community of men having sex with men. Without, outside of those two communities, the rate of reinfection is very, very, very low. Except in Egypt, for example, where in Egypt there is a strong transmission rate associated to healthcare. But this is very specific to Egypt.
Within
Otherwise,
the healthcare system?
yes,
Really?
yes.
Because I know that, that sexual transmission was something that they're, promoting now. That yes, this is the way it can happen. Yeah. So others like the hospital
But
system.
sexual transmission has been mainly seen between men having sex with men because it's associated to traumatic sex or chemsex,
Right.
which means sex and drugs at the same time. So it's very, very specific, to small communities, and it's not a prevalent problem in Africa, for example. The reinfection.
You suppose a very effective prevention program could go a long way in concert with the treatment. Get treated and prevent at the same time.
Yeah, definitely.
So
test, treat, and prevent.
Just exactly.
Yeah.
So you have another trial that
Yes.
you did that you presented
Yes.
today.
Okay, so
yeah.
this is an international trial evaluating the efficacy and tolerability of a new combination of DIAs in HIV, HCV co-infected patients. So this is what we call a pan-genotypic combination. That means that it treats all kind of hepatitis C virus, genotype 1 to genotype 6. So this combination is called lenacapavir and pibrentasvir. The brand name is just new, that's Maviret. And it combines the lenacapavir, which is a drug, anti-protease drug, and then anti-NS5A drug, that's a pibrentasvir. So both drugs are very, very effective against hepatitis C. So it has been evaluated in a co-infected population. So the patients without cirrhosis have been treated with 8 weeks of treatment, and the patients with cirrhosis have been treated with a 12-week course of treatment. And both groups reach sustained virological response 12 weeks after end of treatment above 98%. So that's amazing. So the efficacy was excellent, and the tolerability was absolutely excellent. Only fatigue has been reported. 1 or 2 patients experienced an elevation in transaminases, but very mild elevation, even those with cirrhosis, and no other kind of side effects. And the patients were very adherent, and very, very few.
Is the lack of adherence the reason for the 2%? Do you think? Or do you know? Do you have any idea?
Well, it just patients are failing. It's not really adherence. It's just that's very intricate number of determinants from the host, so probably some genetic determinants, and then from the virus,
but
some resistance polymorphism.
On that.
No, nothing. And with this combination, the drug-drug interactions are very low. So regarding HIV patients treated with ARV, it's contraindicated to use atazanavir, but it's not recommended to use the darunavir or lopinavir, but not recommended doesn't mean contraindicated. So if those patients can't be switched to other kind of treatment, then you can use those drugs and do some drug monitoring. Efavirenz is contraindicated, but really because it decreases the dosing of lenacapavir. So we may face a risk of viral failure, and otherwise all the other ARVs can be prescribed with this combination. So it's very, very promising, especially in patients, HIV-infected patients without cirrhosis, with an 8-week course of treatment.
So there'd be no reason to consider retreatment of any of those that failed a second time, or have you done that? Or?
Well,
based
in
upon
this
what
trial,
you said, it's just,
So regarding retreatment, in this trial, we had patients who had experienced failure with peginterferon and riba, interferon, or sofosbuvir, peginterferon and riba, and it did not impact the response. So it's a very good combination for previously failing patients. Regarding previous exposure to other DIAs than sofosbuvir, we are lacking data in co-infected patients, but in mono-infected patients, it has proved to be very efficient. So that's a good combination for treatment experience and naive patients.
So what is your next step? Do you believe it's time to get the word out?
I hope that we are going to be able to disseminate treatment, first increase the rate of screening all over the world, then disseminate treatment all over the world, and finally reach the ultimate goal, which is hepatitis C elimination. But for that, we have to...
community elimination. You might try demonstration projects in communities. That might be helpful to know.
Oh, definitely.
Yeah,
definitely.
For starters, anyway.
Yeah, definitely. That's the only... I think that if we do not decentralize the care, then, which means that bringing the care to the community and not bringing the community to the care, we won't reach global elimination. So the next step will be really decentralizing care, using point-of-care tests to identify those in need of treatment, and then bring the treatment in the community, and then that will be it.
I think Jono from the CDC, back in the way back, 10, 15 years ago, was doing some Sealand containers with the labs in them and dragging them around the country in Kenya and so forth. And I think, you know, it's valiant to do these things, but it helps to move the whole thing forward and say, this is what we really need to be doing. We've got to figure out how do we, you know, the best way to do this decentralizing and mobilizing the care and treatment so that people can actually get access more where they live rather than, because, I mean, especially in women where they have children, they're going to drag the children with them a distance from one city or from one little town to another. It's very difficult.
Definitely.
So, and yet they do it. I mean, it's still, but it's a burden on the whole community. So I appreciate your taking the time to visit with us, and it was very helpful to get out to our community what you're actually what you're doing. And,
thank you for the invitation to share our results and our view of the future.
Great.
Thank you.
Thank you so much.